purpose of this video demonstration is to teach you how to perform an examination of the respiratory system of a child. And the approach we follow here is focused on the short case. And in a typical short case examination, you will be given about 10 minutes to examine the child and then present your findings and to have a brief discussion. තාත්තා මම ඩොක්ටර් කෙනෙක් මම ඔයාගේ පුතා පොඩ්ඩක් බලන්න කියලා හදන්නේ කමක් නැද්ද? පුතා මම ඩොක්ටර් කෙනෙක් පොඩ්ඩක් ඔයාව බලන්නද? ඔයාගේ පපුව පොඩ්ඩක් බලන්නද? Thank you very much. And make sure that you warm your hands as well adequately so that the child will not feel uncomfortable with cold hands. The first step of doing a respiratory system examination in a child is to have a proper look at the surrounding and the child himself. And you'll be able to get a lot of cues by looking at the surroundings and having a close observation. For example, you may note an inhaler device or you may note an oxygen delivery device closer to the bed. And if a child is connected to a monitor, then it's important to look at the oxygen saturation. And if there is a sputum cup, it's important to have a look at it. And also if there is a temperature chart, have a look and then see whether the child is febrile or not. And before you start your examination, it is important to have a proper exposure to the child. And also the child can be propped up or kept in a comfortable position. And also there should be adequate lighting. And it's very important that you obtain consent from the parent and the child himself. The next step of observation is to look at the child himself. And you might feel, you might see evidence of respiratory distress. For example, child may have nasal flaring and child will have suprasternal, intercostal and subcostal recessions. And also note the pattern of breathing, whether it's predominantly abdominal or thoracic breathing. පුතා ඔයාගේ මේ අත චුට්ටක් බලන්නද මම? So note any evidence of pallu. පුතා ඔයාගේ ඇඟිලි දෙක මෙන්න මේ වගේ කරන්න. Right. කළා ඊට පස්සේ මෙහෙම කරන්න. කළා දැන් එක ළඟට ගේන්න බලන්න. Right. Note for obliteration of the angle between the two nail folds that will indicate evidence of early clubbing. And also look for evidence of cyanosis and then look at the subcutaneous tissues and the muscle mass which might indicate evidence of nutritional deficiency. In general examination, it is also important to look at the BCG scar and presence or absence of any Mantoux test being performed on hands, and also for any evidence of ankle edema. In general examination, sometimes it is important to look for tremors. This is particularly relevant to a child who is on repeated salbutamol nebulizations or intravenous salbutamol treatment following severe V's. පුතා ඔයාගේ අත් දෙක මෙහෙම කරන්න බලන්න උස්සලා. Look for evidence of tremors. One of the very important steps of respiratory system examination is to count the respiratory rate. And this should be done for at least 30 seconds. පුතා normal විදිහට සාමාන්‍ය විදිහට හුස්ම ගන්න හොඳද? Count the respiratory rate and see whether it is normal and appropriate for the age or the child is tachypnic. පුතා ඔයාගේ ඇහැ මෙහෙම කරන්න. So have a look at the conjunctiva, look for evidence of polycythemia and pallo. In respiratory examination, it's important to have a look at the nose as well as the oral cavity. පුතා මං ටෝච් එක ගහලා ඔයාගේ නාහේ චුට්ටක් බලනවා හරිද? So you might see evidence of nasal discharge, hypertrophy turbinates in case of allergic rhinitis, or evidence of nasal polyps, or simply rhinorrhea in a child with common cold. And in examination of the face, you might note evidence of allergic salute or allergic shinners in case of allergic rhinitis. පුතා ඔයාගේ කට අරින්න බලන්න අපි පොඩ්ඩක් කට ඇතුළ බලමු. Look for evidence of cyanosis, palo, or evidence of micronutrient deficiencies. And also look at the palate for any evidence of cleft palate. කට වහන්න පුතා. Next step is to feel the lymph nodes. Here we mainly feel the cervical lymph nodes that are best felt while the child is lying seated and then from behind. පුතා නැගිටින්න බලන්න. මම වගේ බෙල්ල පොඩ්ඩක් අල්ලනවා. හරිද බෙල්ල? So focus on the submental, submandibular and the anterior cervical groups of lymph nodes and then look for any evidence of cervical nodes enlargement. හරි පුතා. And at the same time, it's important to feel for the trachea. And trachea can be felt with your middle finger. And then it might make the child feel a bit uncomfortable, so that you have to be gentle as possible. And then note for any evidence of tracheal deviation. And trachea can be deviated to the same side in the presence of collapse. And trachea can be deviated to the opposite side in the presence of an effusion or in the presence of a tension pneumothorax. Next step of examination is to examine the chest proper. And then you will follow the approach of inspection, palpation, percussion, and auscultation. And remember that you have to do these maneuvers both from front and from behind. And in the inspection, go to the foot end of the bed and then take a tangential view and then look at the thoracic cavity. And you may be able to witness evidence of recessions, chest deformities like pectus excavatum or pectus carinatum, and presence of surgical scars suggestive of previous thoracic surgeries or cardiac surgeries. And it's important to have a proper look at the chest to look for any evidence or any difference in the chest expansion of the two sides. And the next step is to look for chest expansion objectively. So you might need a tape measure. පුතා හොඳට හුස්මක් අරන් හුස්ම පිට කරන්න. හරිද? මම මේ ටේප් එක ඔයාගේ වටේ යවලා ඊට පස්සේ පොඩ්ඩක් මැනලා බලනවා. හොඳද? හොඳ හුස්මක් අරන් පිට කරන්න. ආයි ගන්න බලන්න. It's also important to look at the thoracic cavity to identify any evidence of hyperinflated chest or presence of Harrison sulcus that might indicate evidence of chronic wheeze. The next step of examination is palpation. And it's important to objectively assess the chest expansion using the palpation method. පුතා මම ඔයාගේ පපුව වටේට අත් දෙක තියලා බලනවා. හරිද? ඔයා හොඳට හුස්මක් කරන් හුස්ම පිට කරන්න. And it is relevant to feel for the apex as well, apex of the heart, in some of the respiratory conditions like cystic fibrosis or Carter-Gunner syndrome, where you will note dextrocardia. The next step of examination is eliciting percussion. And percussion note can be dull in conditions like consolidation or collapse, whereas percussion can be stony dull in the presence of a pleural effusion. In contrast, the percussion note can be hyper-resonant in the presence of a tension pneumothorax. And when you percuss, you have to percuss at right angles to the finger of the middle finger of the other hand that you keep on the chest. And then compare the two sides and note for any evidence of dull percussion note. You felt that the note was dull as I moved down the right side, and that indicates the presence of the liver dullness. And similar thing can happen when you percuss over the heart, where you can feel the cardiac dullness. And you will have to percuss the axillae as well. So that is the liver dullness. And you will have to repeat this sequence on the posterior side as well. Next, I will examine for the vocal fremitus. Vocal fremitus can be particularly impaired in patients with consolidation or fibrosis or presence of a cavity. And to elicit the vocal fremitus, you can use your ulnar border of the hand and then ask the patient or ask your child to tell a low frequency sound, something like 99 or 99. පුතා මං ඔයාගේ පපුවට අත තියෙනවා මේ විදිහට හොඳද? මෙහෙම තිබ්බහම ඔයා 99 කියලා කියන්න. හරි? right. කියන්න බලන්න. හොඳට හයියෙන් කියන්න. Good. As you go down the rib spaces, you have to move laterally, because you know towards the lower part of the thorax, the ribs are overcrowded so that there is no enough space for your hand to lie. Therefore, it's advisable that you move laterally as you go down the rib spaces in eliciting the vocal fremitus. The next step of examination is auscultation. It is important to assess the quality of the breath sounds to see whether they are vesicular breathing or bronchial breathing sounds. And also note the intensity of the breath sounds, as their entry or the intensity of the breath sounds may be diminished in some conditions like severe wheeze or in the presence of an effusion. And you can feel added sounds while you are auscultating, and the common sounds include presence of wheeze and presence of crepitations. Crepitations can be either fine or coarse crepitations. Early pneumonia or presence of heart failure may have fine crepitations, whereas a resolving pneumonia can have coarse crepitations. And you might hear bilateral diffuse polyphonic bronchi in the presence of an underlying bronchial asthma. Again, when you auscultate, make sure that you compare the two sides. The second part of auscultation is to assess for vocal resonance. Similar to vocal fremitus, vocal resonance can also be altered in the presence of consolidation, cavity, or underlying lung fibrosis. And you again ask the child to tell a low frequency number like 99, and then similar to the way that you auscultated, you have to compare the two sides while assessing for vocal resonance. පුතා මම මේක තිබ්බහම ඔයා 99 කියලා කියන්න. හරිද? 99. පුතා අපි දැන් වාඩි වෙමු ටිකක්. පුතා අපි දැන් අත් දෙක මෙහෙම තියාගමුද මේ වගේ තියාගමු. So you can ask the child to keep the hands together like this so that you get enough space from behind to repeat the same sequence of inspection, palpation, percussion and auscultation to complete your respiratory system examination from behind. Puta, thank you very much. Well done. Right? අපි අඳ මැද ගමු.